This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be looking at violence against paramedics with Dr. Justin Mausz. So what to do is really examine the prevalence, causes, types, and critical issue of violence against paramedics in the pre-hospital care field. So to do this, I have Justin Mausz with me. He is both an empirical scientist, so he works at Toronto University as a research scientist, but he's also a clinician as well, so balances his time between the two. In this episode, what we're going to do really is get Justin's insights into the growing prevalence of violence in the pre-hospital environment. We're going to examine some of the types of violence paramedics face, such as verbal, physical, and emotional abuse. We're also going to look at some of the contributing factors and offer practical strategies for mitigating these risks. So we're also going to look at how paramedics protect their environment and maintain service delivery whilst in high-risk environments. Justin is a research scientist at the University of Toronto. His focus really is on paramedic education and indeed clinical decision-making and performance optimization for emergency services. So as a dedicated academic, he contributes to advancing paramedicine by combining his practical experience as a paramedic, but also with his research in driving improvements within healthcare delivery. Justin, welcome to the podcast.
Thank you. It's a pleasure to be here. And thank you for such a warm introduction as well.
I wonder if we could just kick off, Justin, by just looking at how prevalent violence is against paramedics in the contemporary climate from your empirical research.
There's a few different ways you can look at the numbers there. I'll give you the numbers from our service, which is in the province of Ontario in Canada, just to the west of Toronto. We looked at this over a 2-year period using a new reporting process that we developed, where paramedics can document violent encounters directly in the electronic patient care record. We found that a paramedic files a violence report every 18 hours, is physically or sexually assaulted every 46 hours, and sustained a physical injury as a result of one of these assaults every 9 days. If you look at it as a function of call volume, it works out to about 0.4% of emergency calls that are associated with a documented incident of violence. But if you look at it as a function of affected staff, that percentage is close to 50%.
Gosh, 50%, that's huge, actually. And especially over the longevity of someone's clinical practice and indeed career, that's huge. Before we sort of get into some of the details, could we just maybe, just for a scene setting, Justin, could you maybe just illustrate a couple of cases that typifies violence against paramedics from either your anecdotal or from the captured research?
I'd love to. If I can, I'll give you 3. And if I can backtrack just a moment to say that having this type of information, I think is really useful from a risk mitigation perspective. So before, when researchers have studied this problem of violence against paramedics, typically they will give people surveys and they'll ask them to estimate their exposure over 6 months or a year, or their career, or they'll talk to them in focus groups, or they'll look at injury statistics. They're all helpful, but they lack granularity about the details of the event at the time of occurrence. And so having this reporting process that we developed, such that when the paramedic goes to an emergency call and fills out a clinical report, if they experience violence, they also fill out this secondary report that gets appended to that clinical documentation. That offers us a lot of insight into the types of violence. And that's where these 3 examples come from, because they're all pulled from that data set. Example 1 is a patient, a resident of a long-term care facility, who has some cognitive impairment and who can get quite fighty with the staff. Sometimes they'll bite, sometimes they'll punch, sometimes they'll kick, but they're generally not, they're not dangerous to the staff. They're not dangerous to the paramedics. There's not a significant risk of them causing serious physical or bodily harm. Example two would be somebody who has epilepsy and the seizures are difficult to control. And when they're compos mentis, they're fine. They're friendly, they're cordial, they're not threatening in the least. But when they're in that post-ictal phase after a seizure, they are incredibly violent and very combative. In example three, as a person with very complex and escalating mental health needs, and we see through successive violence reports that a pattern of behavior is becoming increasingly more dangerous. And they're saying they're making threats that they want to die by suicide at the hands of the police, and they're talking about having access to firearms. So all three of these examples illustrate the complexities of the problem of violence against paramedics. They're all violent. They're all violent in some way, but they demand different responses. And that's where having that event level data that gets very granular, that's tied to the clinical record is really useful.
Yeah, no, indeed, because like you said, sometimes the part of the action or indeed the violent behavior is part of the clinical syndrome and is the confluence or indeed the after effects, like you said, post-ictal state where they're confused and combative, or indeed hyperglycemia is a classic case when someone's hyperglycemic. But to your point, there is this real meld of mental health and intentionality as well, which to your other point really mandates drilling down into the details because it is nuanced and the origins of violence against paramedics. Like you said, it's all violent behavior. It's just different categories. And I wondered if we could just double click on that for a second, Justin, and look at the different categories that you catalog violence in. So maybe the physical, the emotional, and indeed the verbal. Could you maybe speak to that and how the research captured that?
You're not you and you're hungry. So the context matters. It is indeed a nuanced problem. To the definition piece, so we have five, and we're blueprinting our definitions in part off some work by a researcher called Blair Bigham, who's now a physician, former paramedic, now physician. He looked at this problem in Canada in 2014, and he came up with five categories: verbal abuse, threats or intimidation, physical or sexual assault, sexual harassment, and then sexual assault, sorry, is teased out into a separate category. So five. We're marrying those to some occupational health and safety legislation. And so these definitions um, can be parsed out through legislation, they can be parsed out through research, and they can be parsed out through scholarship, for example. Our definitions of violence try to be encompassing, capturing not just physical violence, but these non-physical verbal pieces of violence. And when we've looked at the non-physical verbal violence, for example, that includes verbal abuse or threats or intimidating behavior, we actually did a study where we looked at a year's worth of reports, just the verbal incidents, and we looked for situations where the perpetrators, who are most often the patients, are using language that could be considered sexist, racist, or homophobic. And we found that those sentiments were present in up to 25% of the reports that we analyzed. And that can be enormously impactful to an individual, especially when the verbal abuse is targeting these very personal, deep identity grounds. So sticks and stones can indeed break your bones, but words can hurt pretty deeply too.
No, indeed, absolutely. And 25% is huge actually. And just anecdotally, you to your point, you bump up against these entirely mixed pathologies, which can belie a lot of verbal altercations and again, it's a really mixed bag because there's a lot of addiction in there, withdrawal from addiction, reversing addiction, so reversing maybe an opiate overdose, which again could be classified as a verbal assault if you do reverse. And a classic case in when I used to work in Canada in Vancouver, hundreds of opiate overdoses, reversing that with naloxone. You never quite knew how combative verbally or physically the patient was going to get. And so capturing that is hugely important. And I think partly why I wanted to have this conversation with you, actually, Justin, was to your early point and points you've made on other podcasts is until you have a baseline of understanding of prevalence, you can't then move forward So capturing the baseline, understanding the definition, and then moving to try and mitigate some of these risks is super important. But having that definitive baseline of occurrence and frequency is super important. And I wondered if you could speak to from that statement, the question would be, if you have a semblance of comparison of EMS staff versus police or fire or other adjunctive services, what's the frequency for EMS staff versus some of these other adjunctive emergency services?
So I will say that it's a bit difficult to draw comparisons between professions, typically because of the ways it's studied. So take survey research, for example, which is by far the most common approach that people use. And so they give surveys to paramedics or nurses or physicians, and then they'll ask them to estimate how often they experience these things. You can kind of compare, but it's not really apples to apples because the unit of analysis, the survey, tends to vary quite a bit. There's some work by a researcher called Brian McGuire. He's out of Australia. He uses the United States Bureau of Labor Statistics data, which is a national database that documents injury statistics associated with work. He's done fantastic work on this. His research goes back over a decade, looking at occupational injuries and occupational fatalities, not just from violence, but from all causes, transportation accidents, slips and falls, and the like. But he has done work looking at comparatively the risk of injury from violence for emergency medical services personnel in the US. And what he found is that EMS personnel in the US, so EMTs and paramedics, experienced a risk of injury that resulted in lost time from work or required in-hospital treatment that was 5.5 times greater than the general population in the US, 6 times higher than firefighters, and 60% higher than nurses. So that's where the unit of analysis is consistent, and you can start to draw some comparisons between professions. The one caveat with that is that incidents that result in a physical injury requiring medical attention or lost time from work, tip of the iceberg. Those are the sentinel, really serious cases. Underneath that is a lot of that verbal abuse, which wouldn't be captured, or threats, or intimidating behavior, or sexual assault, or non-injurious physical assault. That I think is the best data we've got.
So I'd like to look and dig into your thoughts on a couple of areas really around um, whether there is a couple of there's provocation maybe from sometimes involved and whether your research passed that part. Before I go down some of these alleyways, could I get you to speak to just maybe some of the primary endpoints from your research, just to outline your research for listeners and just what the research was really seeking to understand?
Oh, thank you for the question. It's one that is dear to my heart because my training is a clinical epidemiologist. So I try and take an epidemiological lens to health issues that affect paramedics. So what's the prevalence? What are the risk factors? What's the burden of disease? Who's at greater risk? What are the impacts on health? But I don't just work in an academic setting. I work for a paramedic service. I work with these people who are affected by these problems. And I think research is most useful when it is a driver of change in an organization, change in safety, change in health and well-being. And our work on this started back in 2019. One of our operations superintendents, a supervisor in the paramedic service, was personally affected deeply by an incident of violence, and she was motivated to do something about it. She sent out a survey to our paramedics, 700 or so of them, asking them about their exposure to violence, if they reported the incidents, and if they didn't, why not? And we found a complex interplay of things largely related to the organizational culture that stigmatized reporting. And we used that initial research as a jumping off point to develop this new reporting process. Alongside it, we introduced new equipment, new training, new policies and procedures, a public-facing position statement of zero tolerance. It took about a year to develop this reporting process. We pilot tested it. We made sure it was regulatory compliant. And then we did a lot of training to make sure the paramedics understood how to use it. And we went live. But it's not just for research. As an epidemiologist, attaching research to this data stream is very powerful for reasons we've talked about. But it is a mechanism that is letting the paramedic service address this problem in real time. Now they have data. They took the data, they took the stack of reports that were coming in from this reporting process to the local government, and they said, we need money for training. And they got $1.5 million in out-of-budget cycle funding approved for comprehensive, high-fidelity, simulation-based training to keep paramedics safe. At the same time, every time a paramedic files a violence report, There's a set of actions that the superintendents, the supervisors need to perform to ensure the physical safety of the crew and support their psychological health and well-being. So it's enormously powerful. And that's been the goal all along, this gap from evidence to practice to narrow it as close as possible to address this issue.
Listen, that's fantastic. And like you said, and it really exposes, but also, but more than exposes the prevalence, there's real actionable data, which has led to service delivery and service improvement, which is absolutely fantastic. Justin, I wondered if we could just look and explore a couple of areas. One would be slightly controversial, but can paramedic behavior sometimes unintentionally escalate violent encounters? And also, how could this be mitigated? Was that a facet of your research, or have you explored that angle?
Not a particular focus of my research, but yes, that happens, that exists. It's a problem we need to address. I would direct you actually to Peter Drew. So he's a researcher, he's a paramedic in Australia. He just finished a PhD. His PhD looked at occupational violence against paramedics in Australia. He did a really in-depth, really well done qualitative study. And he raised this point directly in one of his publications, where he was saying that in order to have safe, equitable, patient-centered care, there's a relationship that needs to happen between the paramedic and between the patient. And we both need to be invested in keeping the patient safe. And if that relationship starts to break down, and it can break down on either end, either the patient who might be cognitively impaired or stressed or in pain, or the paramedic who might be struggling with undiagnosed mental illness or just angry because they're dealing with so much violence on the back end. And that relationship starts to degrade and it can escalate into violence. And I think that's a really important, albeit uncomfortable point to raise when we're thinking about how to respond to this problem. Because yes, it takes at least two people to fight. We, we're both involved in this process.
Yeah, no, indeed, absolutely. Listen, we'll put that in show notes actually for listeners, and I will do some research on that because I think that's a fantastic area as well. Can we just look at hazard flagging as a not just as a concept, but as an actual tool for EMS staff, just to raise awareness of previous encounters and indeed maybe a heightened sense of possible risk mitigation should they need it?
I think it has potential as a risk mitigation concept. So it's something that we use in our service. It's something that other paramedic services in the province of Ontario use. We studied it empirically. We found sort of a mixed bag of results. But the premise is this: if you and I are working together on an ambulance, we go to a house and one of us is assaulted. We file a violence report. Say we're working for my service. We file this point of event violence report. The supervisory staff review it, make sure we're safe, deal with any needs that we have, but then they can generate a hazard flag on the address that we went to, and they can type in some notes. And so if another crew is dispatched at a house for another call, the dispatcher will read the flag out to them, documenting the hazard, and send the information to their mobile data terminal on their ambulance. And the idea, the premise underpinning this is that they will be able to take some precautions or modify their response plan. And that could be any number of things, depending on the nature of the risk. That could be in the hypoglycemia example or the seizure example, asking for another paramedic crew, an advanced life support crew, somebody who has medications for sedation, for example. That could be asking for police for a scene security presence. In that really severe example, where the person is threatening suicide by a cop and they have access to weapons, that could be staging 2 blocks away. So the idea is that we modify the response to try and mitigate this risk of violence. We studied it empirically, looking at about a year's worth of our violence reports, and it's complicated. We found that the risk of violence was higher at flagged versus not flagged addresses. And on the face of it, you would think the system doesn't work. But I think what it's saying is that it is capturing these individuals who have a high risk of violence. It's doing it reliably. And then the other point to this that's tricky is that as the risk of harm from violence increases, their probability of being at a residential address tends to decrease. So a lot of our physical assaults and physical assaults that cause injuries are happening either in public locations or they're perpetrated by people who are experiencing homelessness, and so there's no address to flag. So the concept is sound. I think with refinements, it can be improved quite a bit, but it's tricky to implement.
Absolutely. And like you said, the varying locations and or NFA, no fixed abode, is tricky to tie down, actually, to articulate. Could I get you to speak to some of the social and environmental factors that play into paramedic patient interactions and indeed how they contribute to the risk of violence?
You worked in Vancouver. You could probably tell me about this. I mean, you saw this playing out in real time, and it's worth lingering on for a moment because it's a very difficult. It's a very fine needle to thread. First of all, we're dealing with an enormous problem with drug toxicity events, drug toxicity deaths, with homelessness, with mental health, with addictions, with substance use problems, where we have a population that is suffering because of poverty in Canada, because of intergenerational trauma from colonialism and how we've been rather horrific to our indigenous populations, for example, and this plays out quite a bit in northern communities. There are a host of social factors at play. And so what we have, if you want to distill this down, is a population that has a lot of really complex and largely unmet health and social care needs that has nowhere else to turn and is accessing in Canada's 911, is calling 911 the emergency number, and they're meeting paramedics. And our system, our paramedic system, by and large, is not set up to meet or address these problems. And these two forces are coming together, and it's causing all manner of conflict. There are people who are working to address this problem. I would give a shout out to one of my colleagues, Dr. Polly Ford Jones, who's a paramedic. He used to be a paramedic in Halton region, is now teaching in a paramedic program. But her PhD research and her continuing research looks at how paramedics respond to patients with complex mental health needs. How do we engage them, especially when they're in moments of crisis? And that's great for patients, and that's her lens. How do we provide good, equitable, patient-centered care? It's also really good for paramedic safety because we're going to be able to better meet these unmet needs. So it is a complicated issue.
Yeah, no, indeed, absolutely, absolutely. Can we just speak about balancing safety of paramedics and indeed EMS staff with providing care in high risk environments? Like you're quite right. Working in Vancouver was challenging a lot of times. These safe injection sites, which all and lots of other kind of situations as well, which weren't necessarily that safe at all, actually, and had a lot of unsavory characters, but also just, exposed needles, drug paraphernalia everywhere and on the floor, and indeed a number of drug overdose situations happening in tandem, almost in yeah, more than one occasion, be two or three patients. But could you speak to, yeah, could you speak to this sort of how paramedics balance safety? What's the interplay with providing care in some of these environments?
I'm going to try and strike a line down the middle on this one. Take Peter Drew's paper, his research that he published in the New Journal of Paramedicine, which your readers should take a look. It's fantastic. It's paramedic-focused research. It's largely produced by paramedics, which I think is amazing. His view, essentially, and I'm paraphrasing quite a bit here, is that a lot of the violence that paramedics encounter can be mitigated through good empathic interpersonal communication, connecting with individuals through de-escalation, through crisis prevention, just really being a good empathic human and connecting with people on a very human level and valuing their involvement in the process. And I agree. I think that will solve quite a bit of the violence. On the other end of the spectrum, you have people that say that, this is a workplace and we're not supposed to be exposed to violence. And that's also true. But then they'll say that they're not going to enter any particular scene that has a risk of violence and they need bulletproof vests or body cameras or defensive weapons or self-defense training. And I'm going to try and thread the needle right down the middle there. I do think that there is a significant role to play for being good, skilled communicators, for recognizing early indicators that something might be escalating, for employing good communication strategies to connect with person, recognize their humanity, and de-escalate that situation. At the same time, we go into environments, and you know this well, where we're at an enormous tactical disadvantage. We're going into somebody's home. We might be going down several flights of stairs, past obstructions with no clear exit, into an environment that's dark, that might have other people, that might have dangerous animals, that has access to any manner of weapons, weapons of opportunity or purpose-intended weapons. And the situation that we're responding to, particularly for mental health and addictions, has already escalated by the point that they've called 911. And try as we might to de-escalate it further, there might be a floor on that level of de-escalation as well. So you take that tactical disadvantage in a crisis, in a really uncontrolled and difficult to predict environment, and there are enormous safety risks. So we need to do both. We need paramedics to have really good training in de-escalation techniques. We need care pathways for people who have unmet health and social needs, and we need robust security protections, recognizing that there is a safety risk that needs to be addressed.
Listen, I couldn't agree more actually, Justin. And like I said, a multimodal approach I think is preferable. But again, to your point around, being in an unfamiliar environment on every call, actually, and actually having the sense that any sense that you're not safe, trying to retreat, but it starts at the door. So you're knocking the door and then standing back and standing to the side so that actually initially as you're entering, you're starting to mitigate risk of anything coming, projectile or otherwise coming through the door. But again, to your point, it's the empathic skills of knowing what human connection looks like. And I was always quite worried and concerned if I couldn't get somebody's eyes actually, because good eye contact or lack of eye contact really for me was certainly a red flag of what was happening, certainly within maybe mentally and or physically. Obviously, if there was a physical symptomatology, then or pathology, then fine. But if it was mental health and you couldn't actually engage somebody's eyes, I was extremely wary of the recourse, and actually you get police or indeed retreat slightly. But it's those empathic skills. It's not getting too close to patients that you're unfamiliar with that might be, like you said, in a very pivotal state of recovery or indeed overdose and you've just got to be it's all those mindful skills of just giving yourself those non-verbal barriers of escape really if and de-escalation if need be and all those are very much learnt on the job and learnt as you go, but it's certainly mitigating risk as much as possible to try and limit the impact. Justin, I wondered if we could speak about the COVID-19 pandemic and indeed what impact, either anecdotally or empirically, did you see the COVID-19 pandemic have on violence against EMS staff?
Well, the data for the paramedics, I think, are still emerging. To be clear, most of our work, all of our work, is mid peri-COVID. We implemented this reporting process in 2021, so I don't have pre-COVID data to draw a direct comparison. I can tell you that research looking at other health professions has documented an enormous rise in violence. And we've even seen this play out in the news, certainly in Canada. We had a large protest. There was a protest where people occupied the downtown core of one of our cities of Ottawa, and they sat there for I think over a month or something like that. But they paralleled a lot of other protests that were taking place in front of hospitals where there was growing antipathy and hostility toward healthcare providers. So I'm not surprised that we saw this increase of violence at the same time that this was happening, and the government passed new legislation. So I mean, I think that illustrates how dire it got during COVID. And I think a lot of that had to do with this erosion of trust in healthcare as an institution. And once you start to not recognize people's humanity, I think that's when you set the stage for really, really bad behavior, really violent behavior.
You were, I think there was a dearth of, I think one of the significant things I saw within the COVID-19 pandemic, and it would be nice to get your perspective on this, was because healthcare was so stretched, both in hospital and out of hospital. I think the coverage, the response times, and indeed the care afforded, and I think even the PPE, so the personal protective equipment, really there was a lot of barriers, and it's multifaceted towards patients. So that risk mitigation or that offset of that de-escalation was really hard to, and that rapport building was really hard to attain.
I don't have data on it specifically, but I take your point. I think you're right. I think it is hard to strike a good human to human connection when one of the humans is in a Tyvek suit with with a respirator and a face shield and goggles and wearing a PAPR, for example, and it's really difficult. At least with a PAPR, you could see the person's face, but it's really hard to communicate. Oh my God, we had these reusable particulate air respirators, and they were plastic, and they had two valves, and they sat on your face, and they were really tight until you start to sweat, and they would slip off. So I don't know if they were very effective. You could not talk. You had to yell. You had to yell, even to the person standing next to you. So I don't know how you establish a therapeutic relationship with communication so degraded by this PPE. It's a great point. Honestly, I hadn't thought about it before.
So looking just in at the how we implement more effective risk mitigation tools and strategies, including collaborative approaches actually with other services. So you mentioned before about how the data enabled a package of training that may be involved outside services coming in and training paramedics and EMS staff on how to mitigate risks, either personal protective or indeed otherwise, so could I get you to speak to just this collaborative effort and indeed collaborative approach with other healthcare professionals or otherwise that you've seen in the past and that could be facilitated for staff?
Data is the high ground. When you have it, you've got the advantage because then you can demonstrate the need for something, and then you can build a business case and you can secure funding. And so we've done this a few different ways. This is largely due to the efforts of one supervisor, Andy Johnston, in our paramedic service, who has moved mountains to develop really innovative approaches to mitigating this risk and addressing the problem. So we have an interoperability working group with our regional police partners, and we're able to take cases to them and say we're seeing an escalating pattern of behavior that is either violent or could become very seriously violent. But that relationship, the thing that I really like, works both ways. They will bring the police will bring, I don't know what they call it, clients, people that they're encountering to us who they think could benefit from, say, our community paramedicine programs and the type of services that we're able to offer. And so it's opened the door to improve collaboration. We also do training with the police field training officers, with the staff sergeants, and with the new recruits, where we go and do simulation sessions together. It's not every paramedic with every police officer, but it's key paramedics and key police officers in both. And once they go and do these simulation sessions, they start to realize the capabilities and importantly, the limitations, where those capabilities end. And they're collaborating better on calls. They're more willing to press charges when there is a criminal assault because they're starting to recognize that we don't have the same training, the same capabilities, the same level of risk tolerance that they do. But we have other areas that we're experts in, like pre-hospital care. So again, none of this would be possible if we didn't have good, reliable event level data, and that's been the game changer here.
I'm just going to get you to speak to take home messages if that's okay, Justin. But before I do, just something popped into my mind about just fluctuations in violence against paramedics. And did you see within the data sort of fluctuation from like weekends or indeed night shifts or day shifts? Was there sort of a more prevalent time of day or night or week that these instances would occur?
Short answer, no. I mean, we ran odds ratios for different times of the day, and we found that the risk increased in afternoon and overnight hours. So generally after 2 p.m. and then again after 10 p.m. That's not terribly helpful. It covered a large, covered two-thirds of the clock compared to the one-third that happened during the day. Day of week, I analyzed that 6 ways from Sunday, and I could not find any statistical relationship pointing to an increased risk. If you looked at in aggregate, we had more reports on Tuesday, but it was by four, like the number four, not even the percentage. And it was quite counterintuitive. I was expecting to see that. I thought for sure we were going to see this on weekends. And maybe we just didn't have enough data. Maybe it's the sort of thing if we go back and run some analysis now, we'll be able to tease a signal out of that noise. But for the most part, it just looked like noise. It was happening around the clock on different days of the week in a way that was difficult, at least for me, with my training to predict. ChatGPT might be able to come up with something different.
Yeah, indeed. Um, Thank you for the past 45 minutes, Justin. Could I get you to speak to some take-home messages from indeed the data and the research just for paramedics and EMS staff that might be helpful in their daily practice?
Gladly. A few that come to mind. Not all violence is criminal. I think that's a very important distinction to make. In a lot of cases, I think there are other factors at play. That doesn't excuse it. That doesn't mean that we tolerate violence. I think it just changes how we address and respond to it. I think we need to recognize that a lot of the violence is coming from these complex, unmet social and healthcare needs, and that if we better respond to those needs, not only are we doing better for patients, we're also reducing the risk of violence. In cases where the violence is criminal, no tolerance. We need legislation. We need to recognize that the paramedics are taking on an additional layer of risk, and they're doing it for a noble purpose. Addressing all of that, data is key. You need good, reliable data, and the paramedics need to trust that when they're filling out reports, that the leadership teams are going to take these reports seriously and they're going to action them. And honestly, it's a simple thing to do. Like little things that the supervisors can do after somebody's encountered something like this make a world of difference. Just going to them and saying, I'm sorry this happened to you. Not acceptable. What do you need? How can we support you? Here are the actions we're taking to make sure it doesn't happen to anybody else again.
Listen, that's
Those would
powerful,
be
and I couldn't agree more, actually. Listen, thank you, Justin. We're going to put links to your research within the show notes. I think it's exceptionally important reading, and indeed, just some of the take-home messages are profound and have ramifications for all pre-hospital services, actually. So, but thank you again, Justin. Thank you.
It was a pleasure. Thank you for having me.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.